Hello everyone, I'm Don Simonson, and what I'm presenting today is a sub-study looking at CGM as part of the parent study with dapagliflozin and saxagliptin that was performed. Many of you are probably familiar with the parent study. It's been presented both at the American Diabetes Association as well as at various posters and oral presentations here. But just to summarize it briefly, the parent study involved about 440 patients with type 2 diabetes who were on metformin. And then they were in poor control, and they were randomized to either DAPA plus saxa and continuing metformin, or to glimepiride, and of course continuing metformin. And the primary outcome of that study was lowering of hemoglobin A1C at 1 year. And just to summarize it briefly, because I said it's been presented before, DAPA plus saxa had a reduction of 1.35% at A1C, and glimepiride, the reduction was only 0.98%. The other finding of that study, which is of relevance here, was the change in weight that DAPA plus saxa had a loss of 3.1 kilos over the course of 1 year, whereas the glimepiride had a gain of 0.95, so almost a 4 kilo difference in weight. So what we did in a subset of those patients was look at continuous glucose monitoring, both done at baseline and at week 52. So the sub-study was in 118 patients of the 440. These are the patients who were in the CGM sub-study. They had a duration of diabetes of about 10 years and a mean hemoglobin A1C of about 8.6 or 8.7. So if we look at some of the classic CGM measures that you're familiar with, well, first I'll take a step back. We did an analysis. We have presented here both a per protocol and all patients analysis. And the reason for that difference is because this was a 1-year study, and the patients were just placed on medication at the beginning, there had to be a provision to rescue them if they were in poor control. So the per protocol analysis excludes the patients who were rescued with insulin during the course of the study, whereas the all patients analysis includes everyone. Fortunately, there were relatively few patients who had to be rescued. It was less than 10%. So actually the analyses look quite similar, so I'll just present one and you can see it's similar here. So if we first look at the MAGE, you can see that in the DAPA plus saxa group there was a highly significant reduction in the mean amplitude of glycemic excursion, whereas in the glimepiride group there was actually an increase in the MAGE. Another common measure of variability is within subject, within day standard deviation, shows the same pattern. And as I said, the per protocol and the all patients were similar. There's been a lot of interest recently in nocturnal measurement of nocturnal glycemic control, whether it be hypoglycemia or variability overnight. So we were able to look at nocturnal variability also, and again, per protocol in all patients. So this is the within subject, within day standard deviation. You can see there's a significant reduction with DAPA and saxa and a slight increase with glimepiride. If you look at within subject between day standard deviation, the pattern is it's similar in the sense that there's a much greater reduction with DAPA and saxa, and there was only a slight reduction with glimepiride. This is just a summary of the mean 24-hour glucose. Not surprisingly, it mimics the hemoglobin A1C change. So the beginning to end change in glimepiride in mean 24-hour glucose was significantly less than the beginning to end point change in the DAPA saxa group. We did this table basically shows a number of other measures of CGM. So we have time and range, area under the curve above 10, various between subject, within subject. Most of these are highly significant. All of them numerically favor DAPA plus saxa in the sense that there is less variability. And then finally, we looked at an association between glucose variability and various measures of patient-reported outcomes. I didn't mention it when I was describing the study, but we did a number of questionnaires to look at things like quality of life, general perceived health, weight image, weight quality of life. And the description here is basically that all of those improved more when the glycemic variability was reduced. So in conclusion, we conclude here hemoglobin A1C and 24-hour glucose and nocturnal glucose measures of glycemic excursion and variability showed greater reductions for DAPA and saxa compared to glimepiride at 52 weeks. And the interesting thing is, in the glimepiride group, the increase in glycemic variability occurred even though A1C decreased. So that's a bit of a kind of unusual combination to see a lower glucose but higher variability, which we saw in the glimepiride group. Of course, in the DAPA-saxa group, it was lower glucose and lower variability. The various CGM measures that we said they all numerically favored DAPA plus saxa, and most of them were significant in terms of reduced variability. The CGM changes, as I mentioned, were all associated with improved quality of life. And finally, just to conclude that while A1C remains standard, there's clearly a lot of advantages to using CGM, both in terms of looking at nocturnal variability, of course, variability throughout the day, and its association with improved patient-reported outcomes. Thank you.